the scroll into the lateral mass, a so-called Atala scroll. So, Dr. Hassanain, it's all yours. Please start.
I'm trying to share, but I can't share it with you. I don't know why. Open system references.
Okay. Try to share. When you put share, you see several screens.
Fire off.
I know this guy.
I believe continue with the cases until I solve this problem, if possible.
Okay. Okay. So then, I think I don't know right now which is the case for the craniocervical junction. Jason, is that your case?
I have a case for Atlanta.
Yeah,
it was
craniocervical junction, because I think it's best when we start with this case now, since we have not talked about the Atala screw technique, which will not be helpful for this case. So we start now with Dr. Degiannis. He is our resident in Homburg. He will present his case, which I think he carefully selected as a good case to discuss. So Jason, please start.
Okay. Is my presentation there? I've sent it. I need it. I don't see it currently.
You don't have a computer with you?
No, I sent it to the thing. I can also put on the computer when I need a moment.
It's better you give your computer.
Okay.
Because otherwise it's difficult to forward it.
Okay, one moment.
Maybe Atala, you fix your problem.
About to.
If you put on sharing, screen sharing, then usually you see several screens, and the one with the red frame you select, and this one is who you're going to show. This looks good. Imad, thank you.
Sir, I'm sharing Dr. Jason with him. Yes.
Yeah.
Yep.
Okay, share Jason's, and maybe Atala, you can send your presentation to well, best is to my Gmail account. Then I can forward it to Imad.
Okay.
Or you see with the
Imad.
email I sent you, then he can share it. Okay, Jason, go ahead.
Okay.
Now you have to present.
Perfect. Hello, my name is Jason Degiannis. I'm one of the, as Professor Ertel said, one of the neurosurgical residents at the University Clinic in Saarland. And today, first of all, thank you for the very interesting lecture to begin with. Can we get to the next slide? So essentially, I'm presenting a case with the history. The patient was reported to have cervical reposition. She had developed increasing symptoms in the form of a left-sided numbness in the hand area with slight motor function disorder. Furthermore, she also had recurrent pain radiating in her left arm. She was said to have fallen 3 days before. No higher grade of paresis was seen in the neurological examination. No sign of altered gait pattern, but she showed restriction of cervical movement, mostly in rotation. Inclination also, clear restriction. Next slide, please. So we had radiological imaging done, CT to begin with an angio to make sure that there was no sort of injury to the vessels. And what we saw was the picture beneath. So essentially we see that the dens is dislocated posteriorly. Further imaging was done. Can we get to the next slide? An MRI to show again the exact structures soft tissue injury, and we saw that there was no injury of the vessels and no complete occlusion of the spinal cord. Next. Exactly. So essentially, we did a C1, C2 posterior fixation in this case. What I wanted to ask essentially with this, is there any sort of alternatives? Can you operate such a patient with no neurological symptomatology in an other way other than C1, C2? Would a C0 at any point be an indication in such a case?
Mm-hmm.
Okay, thank you very much. It's a nice case. Maybe Imad, you can go back for 1 or 2 slides to see the instability, to show us. Yeah, maybe one forward. Okay, here you see. Yeah, go back 1. Go back 1 to the MRI. The one before. Yeah. Which you did not point out very well, Jason, is that there was obviously a severe myelopathic signal just at the foramen, just at the back of the tip of the dents. And so although the patient has a very severe scoliosis, we did not really consider doing anything for that, but we thought that this is symptomatic. So what would your approach be, Tobias? Would you go for an occipital or just C1, C2 as we did?
Yeah, thanks for the question. Can you hear me?
Yes.
Yep. Okay. So I got a question for that. Do you have a CAT scan angiogram so that we can judge the course of the vessel up there?
Exactly. That was done. I think it should be on the second slide with the CTs. And we saw that there was no high riding vertebral artery or anything in that case.
Yeah. And the lateral masses of C1 have been solid bone as you expect.
Exactly.
Like
bone quality was good.
Okay. Yeah. So what we saw on that is, well, what I saw, the first thing I saw is the enormous congenital scoliosis. So there are several hemivertebra that result in that terrific scoliosis. And what we saw is that usually the segment C1, C2 is reacting as a consequence of the scoliotic deformity. Usually it's reacting in the left-right direction. Here is reacting in an anterior-posterior direction. The thing is, what I want to say is that this is probably an epiphenomenon on the scoliotic deformity. But now you have a severe problem in the spinal cord at the craniocervical junction, so you have to treat it. I would not, to answer your question, Joachim, include the occiput. I would just exclusively do it C1, C2. But after having done that, I would think about a possible correction of the C-spine or the upper thoracic spine. Because I could imagine that
thank you.
The segment is overloaded. Yeah.
Exactly. That's my concern, is that the C1, C2 will become unstable over time because there's too much force on it.
Yep.
But we will see. It's I mean, for the emergency procedure, I think it was good to address C1, C2.
Yep.
But in the long term, it might become might need a little bit more extensive.
Yep. Can I ask a question in that case? Yeah. Do you apply a intraoperative neuromonitoring for this case?
Jason?
Yes, I see that there's no downside to